Hello, I would like to welcome everyone to today's Systems for Action Research and Progress webinar. Our theme focuses on strategies to achieve alignment, collaboration, and synergy across delivery and financing systems. And the title of our presentation is Multi-Sector Alliances in the Post-Affordable Care Act Era, Key Patterns and Trends. I'd like to present the agenda for today's webinar. My name is Shauna Moore, and I am the Dissemination Director for the Robert Wood Johnson Systems for Action National Coordinating Center. We will start with the introductions, then have our presentation and commentary, and end with discussion and questions. If you have a question or comment, please feel free to type it into the chat box in the lower left-hand portion of your screen at any time throughout the presentation, and questions and comments will be addressed at the end of the presentation. And I would like to go ahead and get us started with our brief introduction of our presenters, Dr. C.B. Mamaril and Glen Mays. Dr. Glen Mays is a Scotchfield Endowed Professor of Health Services and Systems Research in the Department of Health Management and Policy. He is also the Robert Wood Johnson Foundation Director for the Systems for Action Research Program at the University of Kentucky College of Public Health. Systems for Action test strategies for aligning delivery and financing systems for medical care, public health, and social services in ways that improve population health. Dr. Mays directs the UK Centre for Public Health Systems and Services Research in the College of Public Health. He also serves as an Associate Director of the Centre for Health Services Research based at the UK College of Medicine. Dr. C.B. Mamaril is a Research Assistant Professor and Research Scientist for the Systems for Action National Coordinating Center. His research focuses on systems financing and economics. Dr. Mamaril received his PhD in Public Policy and Administration from the Martin School of Public Policy and Administration at the University of Kentucky. He also holds an MS in Agricultural and Applied Economics from Virginia Technological Institute and a BS in Agricultural Economics from the University of the Philippines. And now I would like to introduce our commentary speaker, Ms. Ani Turner. She is co-director of Sustainable Health Spending Strategies at Altarum Center for Value and Healthcare, where she studies drivers of health spending and economic impacts of investments in social and environmental factors that determine health and life outcomes. For the past 6 years, Ms. Turner has led Altarum's work with the W.K. Kellogg Foundation and other organizations making the business case for greater racial equity as a path to a stronger workforce and economy in states and in the nation. Other recent work includes studying access to behavioral health services in Michigan and analyses in support of the on-ground health initiatives in Detroit. Ms. Turner holds a bachelor's degree in mathematics, summa cum laude, and a Master of Arts in Applied Economics with a concentration in labor economics, both from the University of Michigan. And now I would like to hand the program over to Dr. Mamaril, as Glen Mays is traveling today and unable to join us. Dr. Mamaril?
Thank you, Shauna, for the introductions. Thank you also for those who joined us online for today's webinar. We appreciate your time and for registering and signing on. We want to especially thank Ani Turner from Altarum too as well for agreeing to serve as our commentator. Systems for Action is a national research program of the Robert Wood Johnson Foundation. We do want to acknowledge their funding and support for the center and for the research we do. We also want to especially thank Altarum too as well, since this particular study is supported collaboratively by them under the RWJF-sponsored Altarum's Research Advanced Health Reform Program, their current initiative in curating and advancing research to inform policymakers and advocates on topics pertinent to the health reform debate. So I look forward to Ani talk a little about that program and also how this study fits in with the current cohort of studies under their current curating initiative. This Research in Progress webinar series that we host here at the National Coordinating Center is designed to highlight mostly research of RWJ S4A grantees, but for those who may not know, the National Coordinating Center also has its own intramural research agenda that is directed and led by our director, Dr. Glen Mays. So our intramural research team appreciates the opportunity from time to time to be able to participate in this webinar series and share some of the research that we carry out here at the center, as this gives us the opportunity to get comments and feedback that we can use to improve and refine our analysis or ideas and insights that we can incorporate and to our analysis moving forward. And being able to obtain this early in the process, which is the case for this study, is always very helpful. So we look forward to hearing from our commentator today and welcome any comments and suggestions as well that the audience may have at the end of our presentation. I do also want to acknowledge the help and contributions of my fellow intramural research team members, Nerlin Kuzanov, Dominique Zafir, and Shauna Moore for their invaluable input and assistance. So the Affordable Care Act, along with related federal and state reforms, have ushered in an era of resources and incentives for hospitals and insurers and other healthcare organizations to engage in community-wide efforts to improve health. However, not much is known about the population health contributions of healthcare and community organizations in response to these policy changes and interactions with coverage expansions. So, to help fill the gap in the literature in this area, this study has three aims. We want to first examine changes in the multi-sector alliances and public health spending that support population health activities in the post-ACA era. Specifically, we focus on the scope of population health activities implemented by four kinds of healthcare organizations, namely hospitals, insurers, physician group practices, and community health centers. Next, we'll plan to identify the ACA-related policies associated with changes in this multi-sector alliances and spending across states and communities. And lastly, for this study, we plan to determine how coverage expansions may interact with other ACA-related policies in shaping multi-sector alliances and contributions to population health activities. So from the time we formally launched the study last month, we've collected the data and started analyzing it as part of study aim 1. So for today's presentation, we are presenting some of these early results from the preliminary analysis that we've carried out so far. Since we are still early in the process, these results will be mostly descriptive at this stage. So we will look at more general patterns and trends on the contributions of hospitals, insurers, community health centers, and physician group practices. So to measure the changes in these multi-sector alliances, especially those changes related to community health improvement activities of healthcare organizations that comprise the population health network, we use data from the National Longitudinal Survey of Public Health Systems, or NALSYS for short. This survey, which was first administered in 1998, has followed a cohort of some 497 communities with a population of at least 100,000 residents over the last 20 years, with survey data collected in 2006, 2012, 2014, 2016, and most recently this past year, 2018. So starting with the 2014 wave, we expanded the sample to include an additional 500 communities with less than 100,000 residents. In the survey, local public health officials are asked to report on the availability of 20 recommended population health activities, on the types of organizations that contribute to each of these recommended population health activities, the centrality of effort of key actors to coordinate actions in the network, and the perceived effectiveness of each activity in contributing to each activity. So data from NALSYS has been linked with other data sets, and below is just a list of examples of some of the data sets we have linked NALSYS with for analytical purposes. And starting with one of the central components of the survey, which is the data collected on the scope of population health activities that are made available in the community. One can refer to this conceptual framework developed by the National Academy of Medicine, which provides a good overview of these recommended activities, which can essentially be grouped into three general core functions, and that of assessment, policy development, and assurance, core functions which are needed in order to support a community's foundational capabilities for population health. So building on the scope of recommended population health activities, Glen Mays and colleagues developed a typology for classifying multi-sectoral population health delivery systems in communities by also considering the density and centrality of the population health networks of a community. According to this typology, a community is characterized as having a comprehensive population health system if it has a broad scope of population health activities, a dense network of multi-sector alliances of contributing organizations, and central actors to coordinate actions. The scatter plot from Glen May's 2016 Health Affairs paper on these comprehensive population health systems nicely illustrates the positive association between the network density of contributing organizations and the proportion or scope of these recommended population activities that are made available in these communities. And consistent with the cluster-based typology from the previous slide, if you will take note, the observations plotted on the upper right-hand quadrant of this scatter plot would be those communities that have comprehensive systems. Even more consequential in terms of policy implications, also in that same 2016 Health Affairs paper, Mays and colleagues found evidence of positive or improved health outcomes in communities characterized as having comprehensive systems compared to communities not having a comprehensive system. These include lower rates for conditions like diabetes, heart disease, cancer, and influenza. Now, we can also use analysis data to map out the population health network and analyze its network structure. So taking the example of this particular network map, there are two network measures of particular interest, and these are the degree centrality and tie strength. So this network map essentially provides a visual presentation of a jurisdiction's community organizations who participate in population health activities and the strength of their participation. The size of each box represents the proportion of population health activities each organization contributes to. So the larger the box, the greater the proportion of population health activities that organization implements. The thickness of the line indicates the proportion of population health activities each pair or dyad of organizations jointly contribute to. So the thicker the line, the greater the proportion of population health activities that are jointly contributed. So these network measures, as they relate to tie strength, opens up several opportunities to take a deeper dive into examining multisectoral dynamics. So these dyads essentially combine to form what are in effect a type of alliance, since they jointly contribute to population health. In fact, a colleague of ours, Rachel Graham, is currently doing research on these dyads. While this is not the focus of our study, as we mentioned, we do focus on the 4 types of healthcare organizations covered in our survey that contributes to population health, and these are marked or highlighted in yellow, those being hospitals, physician practices, community health centers, and insurers. So this slide and the next slide present the actual maps of the average community population health network using data from the National Longitudinal Survey of Public Health Systems, or analysis. So this upper left map is from the 2006 analysis survey wave, and the lower right network map is derived from the 2012 analysis survey wave. Of particular interest for the study are changes in the network measures of degree centrality, as illustrated by the yellow-colored boxes representing the healthcare organization's contributions to a community's population health network. So continuing on from the previous slide, these are also the maps for the average population health network of a community for 2014, and the one at the lower right for 2016, taken from the analysis survey waves for those respective years. Again, while these maps are visibly small, what we are interested in examining, as represented by the yellow-colored boxes, are those changes over time in degree centrality for our healthcare organizations of interest. So what do we know so far about multi-sector alliances in the population health system? For one, we know that population health activities are produced through highly interorganizational and multi-sectoral efforts. In fact, the majority of these contributions come from outside the governmental public health sector. We know that the structure of population health networks vary widely by communities and changes over time. There's also evidence that stronger networks are associated with improved health and lower Medicare spending. And as we move forward in doing research on these network structures, it is important to consider endogeneity of these network structures. So given what we know and the available data, the progression of our research agenda leads us to take a deeper dive into sector dynamics by looking at the different types of organizations in the network. And for this particular study, that would be the healthcare organizations. So let's start taking a look at the data. Let's start first with the changes over time in the overall scope of implementing recommended population health activities by type of organization. So in this table, that would be the percent change between 1998, when the survey was first administered, and 2016. So two things that we can take away from this table. One is that from the 2016 analysis survey, we find that hospitals are now only second to local health departments in terms of the scope of implementing population health activities. The other takeaway is that with the exception of physician practice groups that saw a reduction in scope, 3 of the 4 healthcare organizations covered in analysis showed an increase in the scope of their implementation. Now, starting with this table and in the next 4 slides, we present in greater detail for each type of healthcare organization the changes in the scope of implementing 19 recommended population health activities in each community. Now, obviously at first glance, these tables are quite busy and presenting a lot of information. So for each table, I want to direct your attention to the last 4 or bottom 4 rows, which groups these 19 activities into the 3 core functions of assessment type activities, policy development type activities, and assurance type activities. So for hospital organizations, we find that between 1998 and 2016, the scope of hospital participation in assessment and policy type of activities increased, while the scope for implementing assurance type activities, such as linking people to needed health and social services, decreased. Moving on, in this table we see the scope of physician groups' implementations of the 19 recommended population health activities. Just as with the previous table, I'd like to direct your attention to the last 4 or bottom 4 rows, which shows how the average scope of implementation across all 3 core functions of assessment, policy, and assurance is much lower in 2016 compared to that in 1998 for physician groups. By contrast, the community health centers' participation in recommended population health activities, as presented in this table, and again, I direct your attention to the bottom 4 rows, which shows that across all 3 core functions of assessment, policy, and assurance type activities, community health centers showed a substantial increase in the scope of their implementation of these activities. Lastly, looking again at the last 4 rows in this table, we see that for health insurers during this time period, it showed an increase in the assessment and policy type activities, especially with the policy type of activities, but had a slight decrease in assurance type activities. So these last 4 tables presented the overall average scope of participation in these recommended activities. But now, in the next few slides, let's see how we can evaluate the changes in the network contributions from these healthcare organizations within a post-ACA framework. So one of the more commonly explored and applied, you could say, analytical policy frameworks when evaluating the impact of ACA has been to examine the variation of impact arising from states that have adopted Medicaid coverage expansion as part of ACA versus those states that did not or have not adopted Medicaid expansion. So as applied to our study, we operationalized this by examining changes in our population health networks and public health spending in communities in states with Medicaid expansion versus those networks and spending in communities in non-expansion states. So currently today we have 37 states, including the District of Columbia, that have expanded Medicaid coverage, and 14 states that have not adopted Medicaid expansion. So in empirically evaluating our community population health network changes, our analytical pre-post sample would look something like this, where we have a non-expansion group that serves as our control or a comparison group of 475 community year observations. And for our expansion group, or we can refer to as treatment group, about 578 community year observations. Also shown in this table is the breakdown by pre and post Medicaid expansion phase, or what you can also refer to as the treatment period. So using that analytical sample, we present in the next set of slides some general descriptive trends and patterns from our preliminary analysis of the data. So in this slide, we provide a kind of overview on the average overall scope of participation in recommended population health activities across the 4 types of healthcare organizations across all 5 analysis survey waves, or the full analysis panel period. Consistent with previous tables, we see a greater scope of participation from hospitals and community health centers compared to insurers and physician groups. The dotted outlines on the bars with the off-colored fills represent the communities in Medicaid expansion states. And while obviously it's not as discernible given the size of the bar charts, a quick glance, one could note a discernible difference in the scope of insurer contributions to population health for those communities in expansion states compared to those communities in the non-expansion group. So starting with this slide and the next 3 slides, we will look at some general trends in the average scope of participation for each type of healthcare organization by core function of these activities. So in all 4 slides, the dotted lines represent the trend reported for the expansion or treatment group, while the solid lines refer to the trend for the non-expansion group of communities. So consistent again with what we saw with earlier slides, one would note that hospitals on average implement more policy and assessment type activities and less of the assurance type of activities. Of interest in these next set of slides would be the discernible gap in the trend line between the expansion and non-expansion groups starting from the year 2014 onwards, when Medicaid expansion was adopted. So from this graph, we can observe that gap that begins in 2014, but in this case, the gap seems to hold only for assurance type activities, while for policy and assessment type of activities, we don't really see much discernible difference in 2016. So for physician groups, unlike the other 3 organizations, and consistent also with the previous slide, we observe a somewhat downward trend in the scope of all 3 core function type of activities. And while we see the same gap between the expansion and non-expansion groups as we would with the other 3 organizations, what's interesting to note is that in 2016, the communities in the non-expansion group saw a higher assessment and policy type implementations of activities compared to those in the expansion group. For community health centers, again, we note the gap between the expansion group, as denoted by the dotted line, and the non-expansion group. And we can actually see a discernible gap between the expansion and non-expansion group, particularly in the scope of implementing assessment type activities. But again, just as it was with the last 2 organizations, we kind of see that gap close in 2016. And lastly, for insurers, a quick glance, one can immediately note the discernible gaps between the expansion versus the non-expansion groups across all 3 core functions, especially for policy and assessment type of activities. But unlike the other 3 organizations, the gap in the scope of implementation when it comes to insurers, that gap holds or remains even in 2016. So that's something interesting to note. So let's now take a look at one of the network measures of interest in our study, and that is degree centrality. And while degree centrality would be in a way related to the scope of implementation, since if you remember, the size of those boxes for each organization in the network were largely determined by the proportion of those recommended populational activities that were implemented, this measure speaks more to the centrality of effort of the organization within the network. And just by looking at the bar graphs across all 4 organizations, one can see how hospitals, given the size of their degree centrality relative to the other organizations, would serve as an important actor in coordinating actions within a community's population health network. So similar to slide 24, the dotted outlines on the bars with the off-colored pattern fills represent the communities in Medicaid expansion states. And again, while it's obviously not as discernible given the size of the bar charts, at a glance and similar to the bar graph shown in slide 24, previous slide, in the earlier slide, one would note a discernible difference in the degree centrality of insurers in those communities in expansion states compared to those communities in the non-expansion group. So, and then looking at the trend in this line graph, which really is just another way of presenting the information in the previous slide, we can rank the organizations in terms of the size of their degree centrality, with hospitals on top, followed by community health centers, physician groups, and then health insurers with the lowest degree centrality values relative to the other 3 groups. Again, the dotted line represents the trend for the Medicaid expansion group, while the solid colored line represents the non-expansion group. Again, we take note that across all 4 organization types, we can see a discernible gap between the expansion and non-expansion group in 2014, but that gap closes in 2016 for hospitals, community health centers, and physician groups. And only for insurers do we observe some type of gap being relatively maintained in 2016. So also in this study, we will be analyzing changes in public health spending within the post-ACA framework. And for our analysis, we will be looking at expenditure data that's taken from the profile surveys administered by the National Association of County and City Health Officials, or NACHO for short. Again, as with the evaluation that we'll be doing of network changes, we are also in the early stages of analyzing the changes in public health spending. But just to set the stage, this table represents the breakdown of the pre-post analytical sample we will be using to analyze public health spending. So the jurisdiction year observations are grouped by expansion, or the treatment group, versus non-expansion, or the control or comparison group, for a total of 10,276 local health jurisdiction year observations to work with. So we plan to analyze the local government public health spending using data from the full sample of observations taken from the 1997, 2005, 2008, 2010, 2013, and 2016 NACHO profile surveys. But we also plan to create a balanced panel of the expenditure observations, which comprises of local health jurisdictions that report a non-missing expenditure value in all 5 waves of the NACHO profile survey. So again, just to emphasize, we are just starting this analysis, so we can't really draw any type of inference from this type of descriptive analysis. However, just as a first pass, we can take a look at the general trend of average per capita public health expenditures, which in this case we express it in real terms in 2014 dollars. So the gray colored line are observations taken from the full sample, and the red colored line is from the balanced panel. The dotted line represents the local health jurisdictions in the expansion group, while the dotted lines, solid lines, are for the non-expansion group. So for both the full sample and balanced panel, and both the expansion group and non-expansion group, we see a general overall decreasing trend in average per capita public health expenditures. Just from a cursory glance, we can also observe that even in this decreasing trend, there seems to be a growing gap in the real average per capita public health expenditures between the expansion versus non-expansion group. Lastly, and again, just from a quick glance, I think it's also interesting to note the relative stability in the trend line for public health spending in the expansion group from both the full sample and balanced panel versus the seemingly more volatile trend exhibited by the non-expansion group in both the full and balanced panel. So again, this is research in progress, and so we are still very early in the process of analyzing the data, which includes applying a difference in differences approach to estimate the impact of Medicaid expansion on the organizational dynamics of the population health network structure and public health spending. Although some of the early results that we've seen suggest evidence of the positive impacts of Medicaid expansion, particularly on hospital insured contributions to population health, but we're still ongoing with that analysis. And lastly, as we move forward, we will also be working on the other two study aims as they relate to identifying the ACA-related policies associated with changes in alliances and spending across state and communities, and exploring how coverage expansions may interact with other ACA-related policies in shaping multi-sector alliances and their contributions to population health activities. So I'll leave it at that for now, and I'll turn it over to you, Shauna, so you can turn it over to Ani. Thank you so much.
Great. Thank you, CB, for reporting on this interesting subject. I'd like to go ahead and have Ms. Turner provide her comments on this project and the topic.
Oh, hello, everybody. This is Ani Turner from Altarum, and we are very excited to be a part of sponsoring this research, as well as the research of a number of other organizations and researchers around the topic of health insurance markets and research to advance our understanding of topics pertinent to the health reform debate. So let me give you a little bit of background on some of the other topics that were funded, so you can see how this research fits into this overall initiative. So Altarum was given a grant by the Robert Wood Johnson Foundation that was entitled Curating and Advancing Research to Inform Policymakers and Advocates on Topics Pertinent to the Health Reform Debate, which is quite a broad topic. But on the curating side of that, we have assembled several hundred citations and organized them into a kind of database in Excel that's available online. And I think that the link that you have in the summary paragraph for this webinar provides a connection to that web location. So anyone can go to that location and sort and filter and take a look at the curated list of research that we've put together. On the advancing research in this area, Altarum solicited proposals for research, understanding healthcare markets, understanding the impact of the ACA on things like community benefit and contributions to population health, some of the mechanisms at work around the exchanges and around health insurance coverage. And we awarded 8 different research projects that we intended to cover a broad range of those topics. So let me quickly tell you what those are. And all of this work will be completed and released and coming out this summer, although for some of the projects where a peer review article is submitted, of course, it may take a little longer for those papers to get published. But all of these projects are ongoing. We have Sabrina Corlett at the Georgetown University Center on Health Insurance Reforms putting out very timely and quick response blogs and short briefs on particular topics of interest, such as reinsurance, state work in reinsurance, and short-term plans and other things that are coming up in a very timely way in the health reform debate. We have Len Nichols and Mehmet Sari at George Mason, looking at a topic that's relevant to the work that we heard today, which is looking at community benefit dollars spent by hospitals. And in particular, their research looks at the implications of hospital versus insurer market power and how that may affect community benefit activities. And they are putting together a database that attempts to quantify and measure different communities around the country and the extent to which there is hospital versus insurer relative market power, which will be one output from that work. We also have funded work related to hospital safety net subsidies and the extent to which the subsidies in various forms seem to match with the amount of care to uninsured and low-income patients is taking place. So how well does the current system of allocating those safety net dollars in various forms seem to match up with the necessary activities that it's intended to fund? And we also have research out of Drexel School of Public Health looking at narrow networks, which have arisen to a greater degree in the ACA exchanges, and seeing how those narrow networks may be affecting access to primary care and behavioral health, in particular for racial and ethnic minorities. And then Alan Baumgarten is looking at Medicaid managed care, and in particular states that have gone one step beyond contracting with managed care organizations for the Medicaid provision and are actually contracting directly with providers and provider networks and looking at lessons learned from those states. And finally, we have researchers at Indiana University looking at the off-exchange markets and how participation in off-exchange health insurance markets impacts and relates to participation in the exchange markets. So you can see that all of these research projects together are intended to increase our understanding of the dynamics around health insurance markets, around ACA and both Medicaid expansion and the exchanges, how community benefit dollars are being affected, how the mechanisms for ensuring safety net services are playing out, and moving ahead to some initiatives like state-based direct contracting with providers to see how some of these market segments might be able to work better. So I'm particularly interested in and excited about the research that we heard about today. We know that in the United States we spend a very high percentage of our total healthcare and social services spending on healthcare relative to our peer nations around the world. And so I think it's very important that we understand the contribution of the health sector to population health and the constructs, the definitions, the structures that Glen Mays and CB and others there have defined, I think are a very interesting and rigorous way for us to begin to understand what's important in these multi-sector collaborations and to help us understand how much each of these actors is participating in and contributing to population health in different ways, and the impact of the ACA and Medicaid expansion on the degree to which each actor is participating. So I was very interested in seeing this early descriptive work and in noting in particular the large gains, particularly by hospitals in their contribution to population health and these activities. It's something that is not unexpected, but it's good to see it quantified and characterized and to have that information out there to inform policy. So I was particularly interested to see that. I am going to be also very interested to see how local public health funding then relates and compares. And I was also interested to see the difference that expansion made to some of these metrics, although I know that there was some narrowing of the gaps over time. But I'm interested to try to understand whether it was aspects of actual Medicaid expansion, such as the impact on hospital or community health center finances, or greater participation on the part of insurers in covering low-income individuals in expansion states that made the difference, or whether it's more something to do with just the general climate, political and otherwise, in states that expanded Medicaid. So it would be interesting to get a sense for what specific things are at play in driving some of those differences. So again, I'm very interested in the work that's been done so far and look forward to the final results and some exploration into what may be driving some of these differences. So thank you very much.
Okay, great. Thank you, Ms. Turner, for your comments on this particular research topic, and also how the myriad of funded research projects will provide efforts towards health improvement. I'd like to now go ahead and open the forum for questions and discussion at this time. Again, if you have a question or comment, we encourage you to type it into your chat box in the lower left-hand portion of your screen. I can go ahead and get us started. I see we do have some questions here. So the first one asks, my community doesn't have a strong multi-sectorial alliance. Health department says that they don't get paid to do this. Hospitals can check off doing a community health needs assessment activity without creating an alliance. And academics don't get paid to do this. What policies, incentives, and system changes will nudge the system in the direction, I'm assuming, of forming alliances and working together? So,
yeah, so
yeah.
So we're going to get into that in greater detail as we move forward in the study, but from what we know so far, some of these incentives, from what is known, I mean, from the ACA and related, federal state reforms would include, the enhanced hospital community benefit requirements, adjusted medical loss ratio requirements for health insurers, value-based payment models for providers, tax incentives for employers, and even the direct federal funding through the Prevention and Public Health Fund. I mean, those are just some of that right now, but obviously as we move forward in our analysis, we'll see how those, interact or could provide or act as incentives for increasing the scope of contributions from these healthcare organizations in the population health system.
Okay, great.
Yeah.
I can go ahead and continue. So I believe this next question refers to your mortality slide. So I'm just going to go ahead and refocus us to this one. And if it doesn't, please change it to the correct slide. But this gentleman says that endogeneity could bias mortality impact in either direction, not just understating the impact. What is the evidence for claiming it just understates mortality impact of multi-sectorial networks?
So again, when we refer to the endogeneity of these networks, and also as they relate to the comprehensive system measure, which is now one of the RWJA's national cultural health national metric. The way that Glen Mays and colleagues addressed this was that taking into consideration that they use an instrumental variables approach because they realize that several measures of public health governance and decision-making structures can also influence both the comprehensive system capital of a community, but have confounding pathways of impact on community mortality rates. So there's been ways to model for this or account for this endogeneity, and so they've used instruments like whether the local public health agency is governed by a local board of health with policy-making authority, whether the local agency operates a central unit state of government, whether the state or local government has the authority to approve the local public health agency budget. So there's been ways to model this, and we're not making any, you could say, general statement saying that it will understate or overstate. It's just needing to account for that. I mean, when we talk about endogeneity in the network, it's so much more looking at also the, the joint contributions. There's a sort of a simultaneity, a relationship going on between the different organizations that make up the network. So, yeah, those are good points again, and those are definitely points that we consider in our analysis. And then there's also another question about these time trends. Again, this is really early in the analysis, so obviously you can't really draw inferences from just taking the simple average, and especially because we haven't really controlled for differences in the community characteristics too as well. So what we're just presenting in this presentation are just really sort of a first pass and looking at the descriptive, trends of these. So, but again, good points, and these are definitely, as we refine and get deeper into our analysis moving forward, these are points that we take into consideration. So I can look at some of the other questions. One question was looking at the population health activities. Does it align with the Universal Chart of Accounts? I think what we're trying to do. This I think is related to some of the finance and spending studies that are going on right now to try to get a handle on public health expenditure data, because this can be quite fragmented, if not standardized across state and local governmental levels. So I know there's a couple of initiatives that are going on to try to generate more reliable and standardized public health expenditure data. Because, for example, with the nature profile surveys, they just give an aggregate, report on what they spent in general for the year in terms of their expenditure. So we don't really see as much information on, whether it was a federal pass-through, was it from local sources, and so on. So, but that's so far one of the best in terms of just having a larger sample of expenditure data observations at the local governmental level. So, yeah, I mean, there's definitely opportunities for that work to move forward. Go ahead, Shauna. We'll try to answer whatever I can answer. We can get in touch with the participants offline.
Yeah. So we just had 2 additional questions come in, or comments. So the next one is, would you please speak about the local health outcomes trusts and how they can help pool resources for building system capital? So
with this, I will have to get back with you offline because I'm not as familiar with this. So definitely the person who asked this question, Shauna or Kara, if you could get their information, I would try to get back to them offline since I'm not as familiar, or I don't exactly know how to answer that question. I think there's also another advice or comment that if you have access to data for a few years back, it might be very helpful to look at time series and calculate upper and lower control limits. So yes, so these are points that as we move forward with analysis that we are taking into consideration too as well. Yes. I think we can end early, Shauna, if there's nothing else.
Yeah. Yes, no.
And again, I'd like to thank Ani and Altarum too as well for joining us, and for everyone who's able to join us today. And if we weren't able to get to your comments or questions, we would gladly reach out to you offline. But definitely, there's still a lot of work to be done. We're still in the early stages of this paper, so we are looking forward to sharing more as we move forward. So thank you, everyone. Thank you, Ani, again, and I'll turn it back to you, Shauna.
Okay, great. We would like to present you with a brief listing of our upcoming webinars, and would like to be directed to our website for complete access to the slides from this presentation, as well as access to our webinar archives on our website under the News and Events section. We hope that you will be able to join us for our next webinar, February 27th at noon, where we will hear about housing for health, cross-sector impacts of supportive housing for homeless high users of healthcare. We encourage you to register for this webinar at our website, systemsforaction.org. We would like to acknowledge that support for this webinar is supported collaboratively with Altarum and the Systems for Action National Program Office by the Robert Wood Johnson Foundation. Systems for Action is a national program office of the Robert Wood Foundation and a collaborative effort of the Center for Public Health Systems and Services Research in the College of Public Health and the Center for Poverty Research in the Gatton College of Business and Economics, administered by the University of Kentucky. I want to thank everyone for joining us for this webinar today. Our presenters, our commentary speaker, and we look forward to hearing from you virtually on February 27th. Thank you, and goodbye.